Leg length deficiency, chiropractic technique analysis, low back pain, and degeneration. Let's look at a new study that challenges previous study results with regard to the effect of small differences in leg length on hip and low back degeneration and pain. Following a review of that study, we'll look at the broader picture of how this might affect a chiropractor's approach to leg length analysis. The title of the publication is Association of Mild Leg Length Discrepancy and Degenerative Changes in the Hip Joint and Lumbar Spine, published in JMPT in 2017. The purpose of the study was, quote, to assess correlation between mild leg length deficiency and DJD of the hip joint and the lower motion segments of the lumbar spine in a population of chiropractic patients presenting with spinal pain, unquote. So who were the participants? There were a total of 255 sets of digital radiographs isolated for analysis from patients in the RMIT University clinics. The cases were primarily of adults between the ages of 17 and 70. So what were the exclusion criteria? Well, radiographs that were not of diagnostic quality and conditions that may have influenced the analysis found on radiographs. Leg length discrepancy was measured as the side-to-side difference between the height of the superior margin of the femoral head using horizontal lines drawn on A to P lumbopelvic radiograph images by the use of a digital approach using micro-DICOM software. Lateral tilt of the sacrum was also measured. These were standing radiographs shot digitally. The results? Greater than 5 millimeters of leg length deficiency was associated with higher DJD values. LLD was found to be primarily associated with the younger age group, and in men for the hip joint, the L5-S1 and L4-L5 motion segments, there was a highly significant difference compared to women. So what was a clinically significant effect size in this study? Effect size was determined through Pearson's correlation coefficient, in other words, the correlation between leg length deficiency and DJD. The highest effect size was on DJD of the hip. For men, it was 28.3%. The effect size of LLD on DJD of the L5-S1 motion segment was 15.6% in men. In women, both of these effect sizes were only 6.05%. For this study, what's unique is that the population was young enough that one would not expect degeneration. The effect sizes were far greater for the hip than the spine, and higher for men than in women. So given the results of this study, it might be easy to extrapolate to the leg check that chiropractors perform and assume that evening out of leg length post-adjustment is even now more valuable. Unfortunately, this very simple dichotomous test used by many chiropractors and the primary indicator for the analysis of a number of reflex techniques is fraught with complication. The first being, are leg length differences anatomical or functional? So first, some definitions. Pelvic torsion or pelvic obliquity occurs when left and right inanimate bones are rotated in opposite directions around a horizontal axis running through the symphysis pubis. Leg length deficiency or leg length discrepancy can be either anatomical or functional. An anatomical deficiency means differences in anatomic length of bones at the lower extremity. And functional LLD means functional differences in the tone of lower extremity muscles from side to side or abnormalities of joint function. So how is this simple complex? Well, imagine you approach a stoplight. It seems your choices are quite limited. Slow down, stop, or go. But let's look at some of the variables. For example, how fast are you going? Important for yellow lights. Are you turning right or left? What's the law regarding turning right on a red? And then the obvious, is the light red, yellow, or green? Now what seemed like two choices, stop or go, turns out to have significant variation. The same is true for leg length deficiency. So there are many questions. Is a leg length difference an indicator of anatomical abnormality in a growing child? If this is true, then obviously orthopedic referral is a strong consideration. Is leg length deficiency present only on weight bearing? Then compensation may be occurring at the foot, ankle, knee, or hip, requiring orthopedic compensations such as foot orthotics. Is LLD an indicator for correction, an indicator of pelvic obliquity, and therefore an indicator of what to adjust? So who has a functional LLD? Approximately 59% of the population has an LLD of equal to or greater than 5 millimeters, and 99.9% of LLD can be classified as mild because it's less than 20 millimeters. This is considered by many to be clinically insignificant. So where should a clinician start? Well, is the LLD on my prone patient the result of an anatomical or structural cause? If anatomical, using this as an indicator for pelvic obliquity would seem inappropriate. Is the LLD on my prone patient the result of a functional issue? If functional, where is it? Should it be corrected first prior to using the prone leg check as an indicator of pelvic obliquity? So how do I know if it's anatomical versus functional? Well, there are two choices, one radiographic and the other clinical. If measured radiographically, choices include a scanogram or a full-length A to P of the lower extremity. If measured clinically, choices include a true versus apparent leg length measurement and the Alley's or Galeazzi's test. There are several radiographic variations of measurement. The orthoröntgenogram involves 3 regional shots at the hip, knee, and foot and ankle, which are then used to measure differences at that joint to determine where the anatomical difference arises from. The scanogram is similar using a different size cassette. The standing version is called a teleoröntgenogram. In this study, Methods for Assessing Leg Length Discrepancy, published in 2008 in Clinical Orthopedic-Related Research, they conclude, quote, a full-length standing A to P computed radiograph is a more comprehensive assessment technique with similar costs at less radiation exposure, unquote. So what about the detection of LLD on clinical exam without X-ray? The standard approach is to measure the supine patient using a fixed point at the ASIS and lateral malleolus for true leg length compared to apparent leg length measured from the umbilicus to the medial malleolus. As you can see, there are 4 possibilities. 2 indicate pelvic obliquity, when either the true leg length or apparent is equal, but the other is not. Now to the other approach, the Alley's-Galeazzi measurement. The title is Mathematical Modeling of the so-called Alley's Test, a Field Study in Orthopedic Confusion, published in Chiropractic and Osteopathy in 2007. As you can see, looking cephalad, comparative length of the tibias should be evident, while looking laterally, comparative length of the femurs. The authors conclude, though, quote, the original Alley's test was developed to identify gross hip deformity in pediatric patients. The extension of this test to adults suspected of having anatomical leg length inequality is problematic and needs refinement at the least. Our modeling questions whether this test can accurately identify an LLI, let alone distinguish a short tibia from a short femur, unquote. So what about the standard leg check for determining what to adjust in the pelvis? Again, this seems simple enough. A short leg indicates a PI ilium and vice versa. Or a reflex technique uses it as a reflex indicator of the need to treat an area or region based on its change to LL due to a stimulus. Let's look at a publication about chiropractors' subluxation finding approaches. It's entitled Review of Methods Used by Chiropractors to Determine the Site for Applying Manipulation, published in Chiropractic and Manual Therapies in 2013. For leg length change as an indicator of site of treatment, there were 6 studies on the validity and 14 studies on reliability. They state that cross-sectional studies fail to show a relationship between low back pain and LLI alone. Now to a publication on what turns out to be reliability, entitled Validity of Compressive Leg Checking in Measuring Artificial Leg Length Inequality, published in JMPT in 2003. This study evaluated the validity and reliability of prone compressive leg length assessment using standardized footwear containing shims of various thickness in one shoe. Artificial leg length differences over 3.7 millimeters were reliably identified, with an intra-examiner inter-class correlation coefficient of 0.85, which is quite high. Other studies of compressive testing include Furr and Osterbauer, Nguyen et al., Schneider et al., and Holt et al., who used prone compressive leg length estimates of volunteers, finding substantial reliability. And here are a number of studies all demonstrating good reliability of leg checks. Let's now summarize using two reviews by Knudsen. In his review, he found that 90% of the population has some anatomic leg length inequality, the average around 5.2 millimeters. Based on the research reviewed, child anatomic leg length deficiencies of 20 millimeters under normal conditions is not likely to cause symptoms requiring treatment. There are some consequences of changing leg length. In the standing position, the innominate moves anterior on the side of the anatomically short leg and posterior contralaterally. The artificial lengthening of a leg causes more rotation of the contralateral hemipelvis in an anterior direction on the short leg side than posterior rotation ipsilaterally on the long side. Walsh et al. Found that pelvic obliquity was the most common method of compensating for leg length inequality up to 22 millimeters. Leg length inequality of greater than 22 millimeters causes flexion of the knee on the long side. There are many factors that can affect pelvic torsion, including innominate asymmetry, freedom of the SI joint, and hypertonic suprapelvic muscles. Now to the question of leg length inequality and low back pain. Freiberg reported LLI of 5 millimeters or more in 75.4% of the patients with low back pain and 43.5% of the controls. Chronic low back pain affects about 21% of the population, so if 5 millimeters of LLI is a causative factor, given that 50% of the population has an LLI of 5 millimeters or greater, there should be a higher percentage. In a study by Fan entitled The Prevalence of Postural Asymmetry in People with and Without Chronic Low Back Pain, radiography was used to determine pelvic obliquity in subjects with and without chronic low back pain. This study found no difference in the pelvic obliquity between subjects with and without chronic back pain. Obliquity was prevalent and equally distributed in both groups. And Gibson et al. Found that at least 10 years after shortening due to femoral fracture, there was no significant discomfort, structural abnormalities, or degenerative changes as a result of the leg length discrepancy. Another study found that in patients with a mean LLI of 9.7 millimeters for an average of 6.6 years after hip replacement surgery, there was no relationship between LLI and low back pain. So Knudsen theorizes that based on some long-term studies, because adaptive compensations to the LLI become anatomic, they are not likely to change moving from a loaded to standing position to an unloaded supine or prone position, so that the torsion of the pelvis remains intact and the leg length at the feet or shoes would appear even on a visual check, so that therefore the functional short leg test is then unreliable as a measure of anatomic leg length insufficiency or inequality. So we have to ask more questions. How is it that different shoes and asymmetrical shoe surfaces don't influence the test result? Does the LLI change with other maneuvers such as stretching the leg by bringing the heel to the buttocks or simply placing the patient in a side-lying position without thrust? Why is it that the same analysis leads to a different treatment approach? So given that the leg check results are influenced by so many variables and the LLD has not been associated consistently with low back pain, the elephant in the room questions include, what if the leg check was eliminated? What does it do to the profession? What does it do to specific techniques? And how would chiropractors make decisions regarding treatment? Can reflex approaches change to a, quote, mechanical approach, such as activator and blocking? And what about the patient's perspective? Some of the positives include that the patient's confidence in an organized assessment of their problem may be helpful. They would believe that chiropractors know how to locate their problem. Some negatives include, how do I know that when they say my legs are even that this is true? How do I know it makes any difference? And how do I tell my chiropractor that regardless of whether my legs, quote, even out, I'm not improving? Some potential harms of continuing to use the leg check are how many patients don't see chiropractors because of the esoteric and unverified approaches for finding subluxations. How many potential chiropractors don't choose the profession because of what is perceived as our fatal flaw, tests without evidence. So let's summarize. A short leg in the prone position might suggest an anterior rotated pelvis if compensating permanently for an anatomical short leg. Prone and supine leg checks don't have any inter-examiner reliability. Prone leg checks are reliable within 4 millimeters with compression. The range of normal LLD is asymptomatic and not consistently associated with low back pain. So, some suggestions for the design of future studies. So what's next, given we have a reliable test, but no agreement on what the finding indicates? First, compare by randomizing into 2 treatment groups with the same management but different analysis, and randomization into 2 groups with one using an analysis that leads to a specific technique approach versus one that doesn't. Again, quite the dilemma. A reliable test that has not been shown to be a valid measure of anything consistently or in particular.